Good morning. I am Dr. Kamil Maroof, a visiting surgical fellow in microsurgery, hand and upper limb department in Ozel Gaziosmanpaşa, Hastanesi, supervised by Professor Dr. Bolent and Dr. Berkan. I'm going to talk to you today about radial club hand, and since this topic is extensive, we are going to talk about it in two parts. The second part will be more about surgical management. Today we will start talking about history. From a historical point of view, the first report about congenital absence of the radius was credited to Petit in 1733. Sayre was the first to perform centralization procedure in 1894, and this was modified later after 1969 by Lidge, and it is very similar to what is used today, and the principles have not changed a lot over the past 120 years. Catou in 1924 collected all the previous cases and in a detailed reference and published them. Evans used a bilobed flap for soft tissue release, and he was the first one to advise that principle. Kessler introduced his soft tissue distraction prior to any surgical intervention concept in 1989, and this was accepted and refined later on by Smith and Green and gained more acceptance over time. Epidemiology and incidence. It is usually an uncommon condition affecting 1 in 50,000 to 100,000 live births. It's a spectrum of diseases. That's why the variability in the incidence reporting. It can range from simple involvement of thumb to a hypoplasia to a complete absence of thumb, radius, or even the upper proximal arm structures. It is the most common type of the longitudinal failure of formation, more than the ulnar side. Boys are usually reported to be affected more than girls, but it has no known interpretation or for this variation. It is usually bilateral, but if unilateral, the right side is usually involved more than the left side. The upper limbs are known to be formed between weeks 4th and 8th post-ovulation. So the critical time for the insult that affects deformation in the radial club hand is thought to be occurring in weeks 4 to 5 of embryonic development. However, the molecular bases exactly are still unknown. We know nowadays that we have 3 spatial axes in limb embryology, and we have the apical ectodermal ridge, the zone of polarizing activity, and the ectoderm, each one of them guiding the spatial orientation from proximal to distal, or radial to ulnar, or dorsal to ventral. The most important one of them is thought to be the apical ectodermal ridge, signaling fibroblast growth factor, followed by the zone of polarizing activity. Radial club hand is usually reported as part of syndromes. A lot of syndromes, including Bactrial, holt-oram, TAR, Fanconi's anemia, chromosomal aberrations, trisomies, deletions, ring formations, other rarer syndromes like DeLange-Dohn, Eves-Houston-Roberts, Rothman-Thompson, Choquer syndromes. All of these have been associated and linked to radial club hand. The inheritance is usually sporadic or recessive. Only the holt-oram is known to be autosomal dominant. Of note and importance is the TAR syndrome, where this condition is a life-threatening condition, and this should take precedence over the radial club hand function in treatment and management, and take the priority to save the life of the child by bone marrow transplantation before dealing with the upper limb deformity. Remember, with the incidence of medical and musculoskeletal abnormalities increases with the increasing severity of the deficiency. So if you see a deficiency like this one, expect to have associated systemic findings in other systems. But take it easy. Also, at least 112 recognized syndromes are described with hand anomalies as part of their expression. This represents only 5% of the congenital hand anomalies. So 95% of your patients will be without associated anomalies. Keep that in mind. Clinical presentation, bilateral cases are more common than the unilateral ones, and usually the involvement is asymmetrical, as we can see in this photo, where the right side is more severely involved than the left side. The main features in presentation relate to thumb dysfunction, wrist instability, and short upper extremity. And these are the three steps that we need to focus on when we think about the management and the treatment of these patients. Associated anomalies of the limbs could be of the proximal limbs in humerus, proximal radioulnar joint, synostosis or dislocation of radial head, in the fingers, stiffness, synostosis, syndactyly, or in the other limb, contralateral radial polydactyly, or even phocomelia. Imaging studies to evaluate and diagnose the condition are important. The X-rays will show us the degree of involvement of radius, thumb, and carpus. However, the X-ray value is better in children older than 8 years of age because it will show the carpal bones and it will show the distal part of the radius mature, which again puts us in a dilemma because we cannot wait to that age before dealing with the patient. So it gives an idea and a hint, but it does not necessarily indicate the exact involvement of the disease. It is also useful to measure the hand-forearm angle as described by Mansky between the third metacarpal and the ulna. And this is useful in evaluating the need for surgical technique complexities and for follow-up in the future. Also, we need to assess for associated anomalies. So we need to order spine X-rays, renal ultrasound, and cardiac echo. Classifications. The first classification system was proposed by Hickel in 1959, but the most widely accepted one is the Bainey and Klug classification proposed in 1987, which was later on modified by Goldfarb to include the thumb deformity in it. So before the Goldfarb modification, it was starting from 1 to 5, and then with Goldfarb we added the N and the 0 for the thumb and the carpal bone as a spectrum of radial club hand. Type 1 is usually with the short radius. In type 2, the radius is hypoplastic and minimal. In type 3, the distal radius growth plate is absent. In type 4, the radius is completely absent. And in type 5, it is involving even the humerus. Kanugia proposed a classification system and assessment criteria in 1985 to evaluate the severity of disease and to follow up the patients. He included originally the hand-forearm angle on the AP view, the range of movement on the lateral view of the elbow, on the examination of the elbow, and the ulnar growth. If bilateral, usually if the involvement is bilateral, the comparison of normal ulna is measured in relation to humerus, which is expected to be usually the ratio between ulna and humerus is expected to be 1 to 1. In unilateral cases, it is easy to compare it to the other side. Later on, Kanugia's criteria were modified. Instead of using the clinical examination of the elbow to assess for range of motion, it is documented by lateral radiographs and of the elbow. Wilkie proposed a severity index for radial club hand because he highlighted that most of the radial club hand patients between type 3 and 4 overlap. Many of type 4 proved later on to be of type 3, but because the distal radius was cartilaginous, it didn't show up on the X-rays. And he noted also between type 3 and 4 that there are different types and variations in the functional impairment, and that does not necessarily reflect that all grade 3s are similar and all grade 4 are similar. So he proposed the HWP, hand, wrist, and proximal part scoring system, focusing on movement of the joints or stiffness, the previous intervention or no intervention before presentation to your clinic, and the involvement of more proximal structures. He classified his system into mild, moderate, and severe, and he proposed that this system could give a better expectation and prognosis for the intervention in these patients, and even in some cases might stop us from intervening in very severe cases that will probably not improve with our intervention. However, he highlighted also that his severity index score should not be used in isolation and should be always combined with the Bainey-Klug classification. The thumb deficiency is part of the radial club hand, is regarded as part of the club hand nowadays. Also, it can happen in isolation, as we said, when it is less than type 1, or it can happen with a more severe radial club hand. The thumb deficiency classification was originally described by Muller and then improved by Buck and Gramko, which is used nowadays, and Mansky. It classifies it into 5 degrees, and it has two. The modification included a subclassification of type 3 into 2 types. In type 1, there are minor hypoplasia of the thenar muscles. In type 2, there is absence of the thenar muscles with narrowing of the web space and instability of the thumb. In type instability of the IP joint. In type 3A and 3B, we have a CMC joint involvement or preservation, stability or instability. In type 4, we have a rudimentary thumb, post-floatant, and in type 5, it is completely absent. The differentiation is important to guide us in our treatment. The most difficult to differentiate is type 3A and 3B, which is often differentiated during the development of pinch and grasp, which develops in a stable CMC joint as the child ages. But again, we cannot wait until this happens before intervention. X-rays give us an idea about the degree of bony involvement, or MRI use is questionable. Is it really indicated or in such a small age? In type 3A, where we have a stable CMC joint, the thumb will be incorporated into object acquisition and manipulation activities, and the treatment will be in thumb reconstruction. In type 3B and more, the unstable CMC joint will make the thumb function often bypassed, and prehension develops between the index and long digits, and further the hand will widen the gap between the index and the long finger and pronate it to try to use it in a purposeful manner, if without intervention. Coming now to our choices of treatment. Our goal of treatment should be to address both the function and the cosmesis and the appearance, but the function is much more important than the appearance. We don't want to improve the appearance of the limb and lose its function. In untreated cases in the past, where it was proposed that negligence is the best policy in dealing with these hands before 1980, it was noted that deformity was not changing between surgical or non-surgical intervention. However, the hand's prehensile function did not develop when no surgery was done. So we need to, our goals nowadays and the consensus is that we need to correct wrist's radial deviation. We need to balance the wrist on the forearm. We need to maintain the wrist and finger motion and avoid the stiffness of them. We need to promote the growth of the forearm and the ulna. And we need to reconstruct the thumb in a purposeful way. And overall, we should achieve an improvement in extremities function. The general principles of treatment now that are accepted nowadays is that we need to start as soon as possible after birth. We start by manipulation and splinting as advised by Flat in a way similar to that Ponseti technique in the lower limb in clubfoot. By applying serial casting, which should be above elbow, changed every 2 weeks, and the child might need 4 to 6 casts in total. This casting and manipulation prevents extensive soft tissue releases when we go to surgery, and it is thought that the child's prehensile functions are easier and better developed with the hand in the correct position rather than when it is not when it is radially deviated. After the age of 6 months, it is difficult to keep the child splinted and cast in a cast. So splinting with a dynamic or molded arthroplast custom-made splint is done, and the parents are taught how to do the protocol of stretching at home on regular basis. Here we come to the surgical intervention, which is going to be spoken about in more elaboration in part 2, including the surgical treatment of the radial club hand, the forearm and wrist, and the thumb. Thank you for listening, and thank you for your attention.